Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing another really awesome guest. We are honored to be joined on the show today by Dr. Neal Baer, who is an award-winning showrunner, television writer and producer, a physician, author, public health advocate and expert, and currently serves and lectures on global health and social medicine, and is the co-director of the master's degree program in media medicine and health at Harvard Medical School. Previously, Dr. Baer was a clinical professor of preventive medicine at the Keck School of Medicine at USC, as well as an adjunct professor in the Department of Community Health at the Fielding School of Public Health at UCLA. There he established the Global Media Center for Social Impact, using new media to ultimately promote global health. Dr. Baer was also an executive producer and showrunner for the shows Designated Survivor, Under the Dome, Law and Order Special Victims Unit, and writer and producer of ER. Dr. Baer is also an accomplished author with various novels, fictional novels, including titles like Kill, Switch, and Kill Again, and the nonfiction Promise and Peril of CRISPR, which we'll be getting into today, a really timely collection of essays on the possibilities and risks associated with gene editing technologies. Dr. Baer graduated from Harvard Medical School, completed his internship in pediatrics at the Children's Hospital in LA, been awarded numerous awards over the years, including the Jerry Pettis Memorial Scholarship from the AMA as the most outstanding medical student who's contributed to promoting a better understanding of medicine in the media. A lot of really cool topics to get into today, and really honored to have him with us. Dr. Neal Baer, welcome to our show.
Thanks for having me.
No, great having you. I'm really looking forward to talking all things with you today. There's several things we don't normally get into, but very excited. I'd love to just start off by handing you the floor a little bit to talk a little bit more about your background. What got you into pediatrics? I know you published a lot sort of in the 90s on various themes in adolescent health, from teen pregnancy to HIV, to even a really cool paper I was reading from 1992, teaching kids about inflation and the cost of living. Very timely nowadays, but take us back a little bit if you would.
Well, I'm from Denver, Colorado, and I say I'm the poster boy for a liberal arts education. I went to Colorado College, and I never studied sociology, filmmaking, screenwriting, or science. I took one science course to um, do my science credits, which was in psychology, training a rat in a maze. So what did I end up doing? I'm a physician, so science. I'm a screenwriter and producer, and I went to graduate school in sociology. So I'm a big advocate for a liberal arts education because it really helped me to um, think deeply and read widely. And I often get asked by uh, students if they should major in filmmaking, if that's what they want to do. And I always say, from my perspective, no. Major in something that you dig into and learn a lot about, because that will help you be a better writer. So um, I've always just been very curious, fortunately, and I grew up, with five siblings. I'm the oldest, so I was teaching them, and uh, I think that's where the pediatrics comes in, because, we're 4 years apart, five of us, because I have twin brothers who are 4 years younger, and then a younger brother who's 8 years younger, and my sister is a year younger, and my other brother is 2.5 years younger. So tight group of us. helping, move things along as the oldest. So I think that's where pediatrics comes from. Storytelling. I just always loved telling stories. So I started out in graduate school in sociology at Harvard and really didn't feel that was my area to go into as an academic sociologist. And by chance, I was at a party one night and I met a documentarian named Bester Cram. And he told me about his job, and something just clicked in me. And I thought, that's what I want to do. And he said, well, you're in luck because there's a visiting professor from MIT coming to Harvard in the fall. This was in the summer of 1981. And he said his name is Ed Pincus. He's the father of cinema verite filmmaking. And you should take his class. And I was obsessed. And I went to talk to him to get into the course. And he said, you can't take this class. You're a graduate student. And I begged him. And he said, but you've never taken a film course. And I left super dejected. Now, obviously, he must have let me in because I'm a filmmaker. He did the next day call me back and said, hey, I thought about it. I was in the same boat as you. I was a graduate student in philosophy at Harvard. I left to make a film called Black Natchez about the civil rights movement. And I've been making films ever since. I went to the course. It changed my life. And I started making documentaries there. I made the first one with a group of students called Nightlife, Jake's Place, and we sold it to PBS about a diner in Maine. I made a second one because they let me take the second year course because they said we might as well. You took the first year. And I made Nightlife, which we sold to PBS, and then I didn't look back. I went to film school. I didn't finish my PhD, just my master's. Went to the American Film Institute, and from there made what was back then called an ABC after school special,
Yep.
and um, and then worked on the show China Beach, which is finally getting released. Like, over I guess like 40 years ago it was on. Because of issues with the music rights. And that starred Dana Delaney and Mark Helgenberger. And the way I got on it was I was in the grocery store in LA and I crashed carts with John Wells, whom I grew up with in Denver, literally 6 blocks away from me where I lived. And he was a producer on the show and said, hey, you should come in to the room and pitch. And I did, and did an episode, got nominated for a Writers Guild Award. It was just crazy. And then my son was born, and I thought, I don't know if I can make it in this town. And I left and went back to Harvard to medical school. In the meantime, I took biology, chemistry, organic, and physics at USC. And I went to Harvard thinking I'll be a pediatrician. And in my fourth year at Harvard, I got the script for ER that Michael Crichton had written
Mm-hmm.
in 1969, 25 years earlier.
Mm.
And it lay dormant in a trunk in Spielberg's office all that time. And Spielberg had forgotten about it. He was going to make it as a film. And he said, let's make it as a TV series. NBC did not like it, despite what they've said, in the past that they loved it. That's not true. They didn't like it. Too many stories, not enough patients, about the patients, too much about the doctors. But Spielberg had done Schindler's List and E.T. and Close Encounters, and Michael had just done Jurassic Park. So they said, okay, we'll do it, but we don't promise anything. So I had a 2 month deal there, and it came out of the gate just like gangbusters. And I ended up doing a show in year two for George Clooney called Hell and High Water, where he saves a kid in the
Mm-hmm.
tunnel. It had 48 million viewers that night.
Yep.
Now, of course, that will never happen again because there's too much competition, too many places for our eyeballs now. Back then, there were four networks and HBO. Now there's, hundreds of choices. So um, that was incredible to think that, like, a quarter of the country or a fifth of the country was watching that night. Even Game of Thrones had 20 million accrued over a
Right.
period. Squid Game recently had 60 million, but that was international over 3 days, and we were just in the US. So it shows you how TV has really changed and the way it penetrates. Back then, it was we made TV and we sent it out to the world. It was unidirectional. Now it's multi-directional. So I ended up staying at ER for 7 years and rose from a staff writer to executive producer, and then left to take on SVU because I'd worked with Mariska Hargitay on ER and we were friends. and they had just fired two showrunners. So I said, okay, I'll try it because I didn't want to be pigeonholed as the doctor writer, even though I am the first doctor writer on TV. Before ER, doctors came in after a script was written and sprinkled the medicine on, which is why ER was so different. It was medicine from the very ground up, the foundation of the show. And the pit is, the ancestor of ER because it's done by folks who were involved with ER and very much that same kind of verisimilitude, and you are there at that moment. So ER changed the way medical shows were done because now there is no medical series that doesn't have a doctor writer in the room.
Mm, yeah. Yeah, it's really interesting. I was looking at it was a very interesting paper you wrote back. This was in 2001 in Health Affairs. It was entitled "Communicating Health Information to Entertainment Media," where you basically, sorry, the main conclusion is, hey, look, you can be educated and entertained at the same time, but there's ways to go about it, and following this, a lot of your publications has to do with the critics say, hey, you're not demonstrating the proper cardiopulmonary resuscitation in this episode, and this is not how psychiatric patients really are, and hey, when you do this documentary over here, you got to kind of balance how much you're showing to the family versus entertaining people. So talk a little bit about that period, because I think it's fascinating, and then also because obviously things change a lot. New media, obviously everything now is online, and we're not always sitting in front of our TVs. But as you do have gotten involved more in, or stayed involved in impacting public health, whether it's sugar sweetened beverages or obviously everything during COVID. How has that ability to educate and entertain, as you've experienced it, sort of changed over the last couple of decades?
Well, ER was path-breaking because there hadn't been a show that felt so real, and we said if it ever happened anywhere, we would do it. But we tried to be as accurate as possible with the caveat that things happen much more quickly. But we didn't put out information that would say, like, drinking bleach would cure COVID or things like that. Everything was empirically based. And so I thought that was an important element. And, I would call the CDC to get information, or I would call professors I had at Harvard to get support for different topics, say blood banking or whatever. And that was kind of the impetus for what's called Hollywood Health and Society, which is at USC, that was funded by the late Norman Lear. And they provide accurate information for free to any writer in Hollywood or New York, because that study was the first experimental study to show that people learn from TV. In the past, there had been studies that were retrospective that said, do you recall this or that? This study assessed people's knowledge of human papillomavirus and its cause, it causing cervical cancer. And then the experimental treatment was the show. And then we resurveyed people afterwards, a week and then 6 weeks after. And we were astounded by the change, like 20% knew that HPV caused cervical cancer. Now, this was in 2000 before the Gardasil vaccine. And then after the show aired, 60% knew. And you have to have that knowledge in order to change your behavior. If you don't have the knowledge, then you don't know how to protect yourself. So we were pretty stunned by that. And that was gave us, reason to really support and my involvement in Hollywood Health and Society, because I knew that providing accurate information had an impact because people learned from the show. And there was a big debate, believe it or not, maybe 15 years ago, might have been a little bit more, when I believe a show on ABC said something about an association between autism and vaccination. And already at that point, it had been shown that the study that was printed in Lancet was falsified and retracted, and the researcher who wrote it was lost his license, but the damage probably was done. So at that point, the networks really, to their credit, asked the writers to provide the data for what they said. And that was really, I think, helpful. And thanks to Hollywood Health and Society for that, because they provide the data. When I did a show on measles, I'm a physician, but they said, show us the data. And I did. And it came from the CDC. Now we're in this horrible conundrum where we can't find the data anymore because it's been deleted and things like that. So it's so even more important to be accurate. You mentioned the CPR debate, and that was
Yep.
really interesting because researchers from Duke asked me for every episode of the first season. They were big fans, and then they wrote a piece for the New England Journal saying that we showed CPR to be more effective than it is.
Mm.
And I was asked to write the rebuttal, um, and I said that there were problems with the data, and the problems were that they um, also looked at Rescue 911 and and that always had good outcomes because it was called Rescue 911, not Death
Right.
911. So that skewed the data. But the point that they made, I think, was well taken, which I said is that we have to be very careful and very clear that we don't resuscitate, or if we shock someone whose heart is stopped, that's not going to do anything. That's not going to shock them back. This is not Frankenstein shocking them to life. If they have an arrhythmia is when we do that. So we wanted to be really clear. And I did an episode where Noah Wiley resuscitates an elderly gentleman, but breaks his rib, punctures his
Hmm.
lung, and he's really super stoked. And Juliana Margulies' character, Carol Hathaway, is like, "Oh my God, what has he done?" So I wanted to show that. Also, the problem with that study was is that every instance of CPR was noted as equal, but sometimes in the show we'd have a long conversation about whether to resuscitate someone, and sometimes it would be boom, we do it. And so by making them kind of equal, it was also skewing the data. But I was really clear in saying that they had a good point, and this has come up a couple years ago in the New York Times, it was written about again, like is CPR shown to be too effective. So we have to be really careful because audiences believe what they see because we go to such an extent to make it look real. Like we don't use cardboard backgrounds. We shot in a real defunct hospital for the pilot of ER and then recreated it literally on stage 11 at Warner Brothers, where in fact Casablanca was shot on the same stage. So it was pretty great, like the ghosts of Bogart and Ingrid Bergman, um, and many other movies. And so the only difference, if you look at the pilot and episode two, is that the hallways are wider to accommodate the Steadicam, and the floors are made with linoleum, not glass tile, because those would have broken. But otherwise, it's pretty much what you see in the pilot. So we were very lucky to get this defunct hospital in East LA that had amazing sight lines where you could see it all the way through, across the ER, and then you could pull the shades in the trauma rooms and things like that. So with the the trauma room and the ER itself was another character along with Clooney and Anthony Edwards, Sherry Stringfield, Noah Wiley, Eric LaSalle, um, Anthony Edwards, and Juliana Margulies. So those were the original characters. Um, so I've written a lot about, what I think is ethically acceptable, and I wrote a piece for several journals, JAMA, and also a clinical ethics journal of clinical ethics on whether it was appropriate to allow a documentary camera crew into the ER. And at the Brigham, which is a Harvard affiliated hospital, they had a kind of a Dr. McDreamy, like Grey's Anatomy, and they followed ER docs. And I wrote a pretty scathing piece in JAMA called "The ER comes to the circus comes to the ER,"
Yep.
and said that the difference is that on ER, we all go home at night and we're performing. The actors are performing our words as writers, and nobody's, you know, aware of the camera in terms of a life or death situation. Whereas I had real um, worries about bringing cameras into the ER and saying it wasn't going to have any impact on the physicians or nurses or the patient. Because having made documentaries myself that are cinema verite, people get used to the camera, but they always kind of know that it's there. And I don't want doctors second guessing what they're doing or, being worried that it's being recorded in an ER. I don't think that that's appropriate place for making entertainment. And you asked me about entertainment and education. I never think about this horrible portmanteau, edutainment. They said, "Oh, do you do edutainment?" And I say, "No, I tell the best stories I can. I don't
Mm,
think about educating anyone. I just provide accurate information in regard to the story, but I don't stop the camera, I don't stop and say, point one, do,
right.
facts. It's all integrated into the show. And two, I think entertainment has a pejorative kind of sense of you park your brain, at the door and you go and sit on a couch and get entertained and it kind of washes over you. I'm interested in telling stories that transport people that they can relate to, they can bring the template of their own lives to, and maybe change their mind about something because they see the characters grapple with these issues. And I guess an example I love is from SVU, where I did an episode where um, a mother euthanizes her baby who has Tay-Sachs disease, which is a genetic disease that is absolutely incurable,
Mm,
absolutely causes death at a very young age, and the child suffers. And there's nothing we can really do. And so, and as a writer, you can construct these kinds of scenarios. And she euthanizes her baby with the help of her doctor, her pediatrician. And the characters, Mariska's character, Chris Maloney's character, the late Richard Belzer's character, and Ice-T argue over what she's done. Whereas Maloney's character says, "I'm the father of five in the show, and I would never let my child suffer, and I'm all
mm,
for what she did." And Belzer says, "I'm Orthodox Jew and it's up to God." And Mariska says, "I don't know." And so they're all kind of stand-ins for us, for the audience.
yeah.
So I always loved being able to attack an issue from multiple perspectives and let the audience kind of think about what they would do in this really tragic situation, with of course the usual SVU twists and turns. So I've been really fortunate to provide episodes. I've done probably about 500 episodes of television at this point in my career, and I don't know that there's a subject in health that I haven't touched on. So I've been very, very fortunate. But I really thank, you know, Hollywood Health and Society because they're there, and we do offer um, experts, from around the country to go, especially now with Zoom, to go into the writer's room to provide accurate information. And I'm really very grateful to the networks, both the streamers and the broadcast networks, that they do, want to see the data because this is a big problem, as you know, of course, as we all know now, which is, you know, data are just another opinion. In an SVU episode, a mother who has not vaccinated her child from measles, and he's 5, and he goes to the park, and measles is one of the most communicable viruses around. Um, he exposes a little girl who's under a year who's in the park, and she contracts measles and dies. And so this was one of the first episodes about 2008 that posed the question, what's your responsibility to your children, but also to the community of children. And we don't vaccinate children under a year for measles, mumps, and German measles. So what's the answer? Don't take your child to outside until they're a year old, or vaccinate your child. And what about kids who are immunocompromised? And interestingly, just this week, the Surgeon General from Florida, Ledopo, who went to Harvard, and, you know, unfortunately, we have to, you know, take him as one of our alums, said that he didn't really look at the data and it's really
Mm,
up to parents. And he was asked, there shouldn't be a vaccine mandate. And he said, well, what about immunocompromised children? And he couldn't, he said, well, yeah, that is an issue. I mean, this is where we are. So we have the data. We have so many studies about autism and vaccines. Um, and so we're in this really treacherous place that science is just another opinion, as the mother who didn't vaccinate her child. And Stephanie March's character, the assistant district attorney, says, your opinion killed a child. And
yeah.
so that's where we are. And that's why I love doing what I do, because I get to get entangled in these really tough issues and pose these questions. What about the community of children? What about the children we can't immunize? Should they just be, stuck in their homes and not go anywhere because we don't know if a child's been immunized? What's our responsibility, of course, to our own children? And what's our responsibility to the community of children?
Yep.
And if a doctor says one thing and you believe something else, how do we have that conversation besides just on X saying, I don't
Right.
believe it or I do believe it? So that's where we are. But I think I've been really lucky because guess what? People watch SVU over and over and over on many multiple platforms. I'm so grateful for that. So, it gets out there again and again.
Yeah. No, it's a great position to have been in, and you do a great job of it. So hats off to that. Yeah, we are in a very strange time right now, and I'll agree. I'll just echo that, and and we'll move on to the topic, the big topic of the show, and that's CRISPR. And it is interesting. One other paper I was going to bring up because this sort of segues into the book, but you wrote this back in the winter of 2020. It's in Johns Hopkins University Press entitled Code Dread. I think the Doudna Charpentier Nobel Prize was just announced maybe a couple of weeks before you wrote this. But you start out, hey, CRISPR keeps me up at night and I'm worried about a lot of things. Before we get into sort of the good, bad, ugly, neutral of all things CRISPR, I was wondering if you could just reintroduce our audience. We've talked a lot with guests that are using CRISPR now in various projects, but one of the interesting things about it, I mean, we know about the Doudna Charpentier paper happens in 2012, the Nobel in 2020, but it really goes back a couple of decades before that, and it's sort of an example in many ways. I think a lot of people think people win Nobel Prize like eureka, and I get the Nobel Prize. No, this goes back to the early 80s in Japan, where some of the first things that were called CRISPR sort of emerge. Just talk a little bit about what CRISPR is again, and a little of the history of how we
Right.
ultimately get to the Nobel Prize.
Well, it goes back to Dano yogurt and
Mm-hmm.
uh, the yogurt scientists noting that there was something odd going on that some yogurt would spoil and some yogurt would not.
Yep.
And why did some yogurt not spoil? And it's because the bacteria was cut up and incorporated into the genome. And that was the beginning of this idea that you could possibly, with enzymes, cut DNA and do things, to replace it or um, make it less harmful, or if it was bacteria or things like that. So it started, as far as I've read and understand, with these food scientists who saw what was going on, and then Doudna and Charpentier knew about that and then started doing this seminal research. And Doudna says that she has dreams, about Hitler and things like that. Of course, she still moves forward with her work, and has many financial interests in CRISPR. Um, so, um, so it interested me because, again, stories are what I trade in and do. And I had a patient when I was an intern at Children's Hospital Los Angeles with sickle cell disease. And
Yep.
she was a young black teenager, and she was dying because she had had a blood transfusion. And back then, we had just paper files, and she had just, a set of charts that literally was like 6 feet tall, and buried somewhere in one of them was that don't transfuse, but you would not really, it hadn't gotten transferred up to the present. So she had been transfused. And when I came on with my team, as the intern and the resident, she was having a transfusion reaction and she had suffered. These kids often have strokes. It's just a horrible disease. 100,000 Black Americans in the US have sickle cell disease. About 8 million, it's estimated, do around the world. And so I was just always very concerned about how they get treatment. There are often kids who are, poor, maybe have less access and in terrible pain, and often seen as drug seeking for pain when they have probably what's amongst the worst pains these joint pains that they can have. So I was really always interested in when CRISPR started being talked about, I was interested because it's just a mutation of one letter that causes this in the DNA. And so with CRISPR, there was a possibility that it could be treated. And so what CRISPR is really a cut and paste um, uh, technology where an enzyme goes in and cuts the mutation out and replaces it, matches it, and then replaces it with the proper sequence. And so with sickle cell disease, they don't change the sickling blood. What they do is they turn on the fetal hemoglobin. When the fetus is in utero, it has fetal hemoglobin, which binds more strongly to the oxygen in a mother's blood. Um, but that turns off when we're born. So CRISPR turns on the fetal hemoglobin gene again. And so it floods the child's body or the adult's body with a different hemoglobin that's not sickled. And so there have been kids and adults now who've been cured, as with beta thalassemia, another what we call hemoglobinemia, and some rare protein folding diseases. And how has this been able to be done? Well, it's not so hard to deliver CRISPR to the blood because you just inject or transfuse, or the liver because the blood is always going through the liver. It's harder to do this with, say, cystic fibrosis or Duchenne's muscular dystrophy to really get it to the muscles or get it to the cells in the lungs. It's not every cell in the lung that has CF, which is a channel uh, uh, disorder of the channels that bring in sodium. So that's still being worked on, but we can and have done amazing work uh, to cure people. It's very expensive, so that raises other issues about who's going to get CRISPR for, say, sickle cell disease. There's so many people, but it's super expensive. You need to be hospitalized. You have to have your bone marrow ablated. So there are those issues, of course, and companies don't do it for, they do it out of compassion, of course, but they also do it to make profit. So how are we going to, is Medicare, Medicaid going to pay for it? Very expensive, even though it costs over $1 million. Like I think like the last data I looked at, like 1.6 million over a lifetime to treat sickle cell disease, a shortened lifetime, much shorter than the average lifespan, and like 50 to 60,000 out of pocket for the family. So it's a very expensive disease and a very, more importantly, harmful for the child, the family. It's really, really devastating. So I'm all in favor of treating people with CRISPR to alleviate human suffering. I'm all for that and to make it available. But, there are caveats. So when you're doing like when you're correcting, and you've seen this on your cell phone when you type something and it changes it to a different word, and it's like, you know, that can happen with CRISPR, and we call that an off-target effect, where we're trying to target certain parts of the DNA, and there might be something else that happens down the road or on the DNA that's called an off-target effect. And we have to remember that our DNA just didn't pop up, when we're born,
Right.
but that it has evolved over hundreds of millions of years. And a really good example is a gene called what is it?
And
PSK9, I
yeah.
think is what it is, but we can look it up. It's the gene that controls LDL and cholesterol.
Yep.
And so there's been some really interesting work done by, I believe, the company that does the sickle cell work, Vertex, where it's called one and done. And, people who have a family history of high cholesterol, cholesterolemia, they don't often respond well to statins like Lipitor, the ones that we give people. And they don't even often respond well to Repatha, which is a shot once or twice every week or every other week. And so with the early studies of this drug, um, it's lowered LDL like 70%. And it's infused once. That's why it's called one and done. And boom, it knocks out that gene. But if you go online and look at on these amazing AI platforms, you can see the history of this gene, and this gene just didn't pop up 100 years ago or 1,000. It's been evolving over millions and millions of years and also controls other things. So I think when we want to be doing this one and done, we have to be really cognizant of downstream effects,
Yep.
even though there weren't any deleterious effects in infusing it, what's going to happen. And so, yes, it would be great if we can control LDL, and particularly in these folks who have high risk of heart attacks when they're in their 30s. That's great. But we have to also be careful that we're not just jumping in and like, well, we're going to, you know, you know, you know, do one and done on that gene. And,
Right.
and so I think we have to be really careful in looking at down the road effects. So that's the part of CRISPR that we call somatic gene editing. We're
Yep.
editing a gene in the body that is, throughout the body, but affects a certain part of body's function versus um, germline editing, which means editing like an embryo so that you change the germline or the sperm cell or the ovary cell so that that embryo will pass on that CRISPR to future generations.
Hmm.
And somatic editing doesn't affect the germline. So someone who gets a sickle cell treatment can still pass their will still pass their sickle cell gene because they have the two genes. It's uh, um, it's you need both parents to give you, it's a 1 out of 4 because both parents have to be carriers. So it's a 1 out of 4 chance that the child will get both genes. But if that child grows up and has had CRISPR, they will definitely pass on their sickle cell gene because it
Hmm.
hasn't affected the germline. But the two babies, there was an embryo that was CRISPRed in China by Dr. He, and it split into twins. They were CRISPRed in the sense of they had a receptor for HIV that was
Yep.
CRISPRed, and so that they wouldn't be able to contract HIV. But again, there's some evidence that um, people who have that mutation are more susceptible, I believe, to other viruses, maybe like
Right.
West Nile virus, because in evolution, things change. Like, why do we have sickle cell disease? Well, it's believed that we have it because if you have just one gene, you're a carrier, you have some effect of the disease, but not in the serious way of strokes or joint pain, but maybe some effect. But it may be protective against malaria. And so that's why it tends to affect Black people in the United States and around the world because it developed in Africa as a mutation to protect. So if you have this gene, you might be protected, but that's the good. The bad is if you get both, you're in big trouble. So there's like evolution has made this decision in a sense of protecting the most people with this mutation. But uh, so evolution is complex, and I think if we want to go in and say, well, one and done, boom, and of course they've looked at impact, but I think it's hard to know down the line, when genes do more than one thing. So
Yep.
I express a lot of caution. And also with germline editing, it then starts to raise the question, of course, of enhancement. And you know, are there genes that are for, stronger muscles or intellect or whatever? There is no gene for those, one gene for those things. It's a combination of genes and, of course, environment. But there are things, purportedly Russians and Chinese are doing research to make soldiers who are fearless. There are genes that, might make us less fearful. There are definitely genes that make us not feel pain. There are children who are born who don't feel pain, and it's terrible because they break their bones all the time, and then they try to show people that they don't feel pain, and bad things happen when they jump off buildings and things like that. So, or maybe we know of genes that confer on people that who they'll need much less sleep. So we could start to like try to like make soldiers who don't need as much sleep, who don't have fear, um, and who don't feel pain. Yikes,
Yeah.
so so that's the peril. In my book, The Promise and Peril, I've said the promise, which is, yeah, I'm all for curing horrible diseases. The peril is I'm not for doing experiments on embryos to produce enhancement or super soldiers or things like that. And also, we've been CRISPRing for years in the sense of um, hybridizing plants.
Yeah.
That's kind of a CRISPRing sort of thing, selecting out genes and also doing it for animals. But then now we're at the place where we can use CRISPR to do what's called transhuman research. And, we can put human genes into animals and make more human-like kidneys. But what if we start doing things that could make them more sentient? I mean, animals already are sentient. That's a chapter in my book. So I really worry about all these things, which aren't really talked about. Instead, we're talking about whether we should vaccinate people. We're in like such like almost the medieval ages again
Yeah.
of science. And then science is moving forward. We have a terrific piece at the end of the book by Ben Hurlbut, who's a professor of ethics at Arizona State University. And he talks about how science often leads the ethics. And he talks in his piece about how Dr. He in China was encouraged by scientists in the US to go forward because the scientists knew Ben was at these meetings. This Dr. He was encouraged to do this because these scientists knew they couldn't do it in the United States. It's illegal. And they, they said to him, you could get the Nobel Prize. This would be great for China. And Dr. He did this. And you know, China put him in jail for 3 years, but still, Pandora's box was open, the genie was out. And so the American Academies of Sciences, Engineering, and Medicine and other organizations in 2015 around then would say there's no reason to do germline editing. And they started to change their tune a bit after Dr. He and said, well, maybe there are some circumstances for that. And they give an example, which is quite interesting, which is um, in terms of genetic diseases, you don't really need CRISPR to prevent them. You need CRISPR to treat them.
Yeah.
But the way to prevent them is, and you need to do IVF if you're doing CRISPR on an embryo, of course. So what we have is called PGD, pre-implantation genetic diagnosis. And so if a family carries Marfan's or Tay-Sachs or cystic fibrosis, we can look through IVF at a fertilized egg and not implant or sickle cell disease and not implant an egg that carries that genetic mutation so that that child will never be born, a child will never be born with that. So we have the means to do it without treating them, and when they're born and already suffering. So I'm all for that. Of course, we have a lot of debate about IVF now. Plus, IVF is super expensive and it has, intense side effects for the person who's donating the eggs. So, so that's a big issue. But there is a circumstance that's not so rare. I mean, that there are very rare circumstances, like if both people carried Huntington's disease, but it's unlikely that would be billions to one. But there is a circumstance, and that is that there are many um, mutations that cause deafness. And
Okay.
deaf people often have spouses who are deaf because they meet in places. The biosocial, what we call the biosocial elements are they go to meetings, they may go to school with people who are like themselves. They may be in deaf communities. So the argument is that if they both carry the gene for deafness, they're going to have a child who's deaf. So for certain kinds of deafness. So you could do IVF forever and look at the fertilized egg and screen it, and you're never going to find one that doesn't carry deafness. So they say, what if those parents want to have a hearing child? we need to do CRISPR. And so this is like the unusual, what we call the unusual, the exceptional case.
Yeah.
And that's used to justify maybe there is a time to do this. And Hurlbut argues, I think rightly, that once you go down this road, then it gets easier to keep going down the road. And so that's what worries me.
Uh, Yeah, you brought up so many interesting points, and again, looking at the case of Dr. He, and he does his germline editing, he goes to prison, and that story gets so much attention. But the flip side of that story, and we profiled on this show one of the HIV cure cases out of City of Hope in your area. I think it was patient number 4, and there, okay, it's not a germline edit, it's a somatic edit. We take these blood cells and you make them immune to HIV, and now we've
Right.
cured a patient. And so and I'm saying something dirty here. I'm going to say gain of function. I mean, gain of function has this really bad connotation. But hey, if I'm gaining function and making someone resistant to HIV, or I'm making these CAR T cells over here at Penn that much better at killing cancer, I like that gain of function. I know a lot of people are hesitant nowadays, especially in this whole conspiracy environment that we're in. But I wanted to come back to one other thing you talked about, because it's kind of interesting, and I've done a couple shows on the whole area of xenotransplantation with Bob Montgomery at NYU and David Cooper over at Harvard, and I'm kind of surprised at how far xenotransplantation has come. I never thought it would keep up with. I thought we were going to be printing organs and all that stuff by this time, but it's happening right now. There, we're not talking about one gene. We're talking about multiplexing and dozens of genes that make those organs a little more human. Get rid of the viruses, of course. I saw you on a previous show talking about your concern. Great, we can have a human heart and a kidney in there, but we don't want a human looking brain in that pig. That brings up all sorts of weird sci-fi stuff as well. Say a couple more words about that, because I think I don't want to gloss over that point,
Right.
because I think it's kind of important
Well,
with how
the
that area
island
is
of,
evolving.
yes, the island of Dr. Moreau
Yeah.
comes true. I just think that we have to be really thoughtful about it's not just about us, we're animals too. So, because we have the means to do it doesn't mean that animals don't have rights. And so, what are we doing to them? Are we doing something that evolution has not done? So there have been all kinds of experiments making big basset hounds and things like that. I haven't looked lately, but you could order online a CRISPR kit to learn CRISPR to
Yeah.
make giant tree frogs. And, kids do this in biology class, and I think it's important. We have a great article about the person who was teaching the public about CRISPR, Ellen Jurgensen, who uh, did the first kind of DIY labs for this. And students, can make yeast fluoresce by CRISPRing a gene. And that's pretty cool to learn about CRISPR that way. And that's yeast. But the yeast are not basset hounds that, we love and they
Right.
love us. They're not pigs that, don't just exist for pork chops or bacon, but have lives and have feelings and, and have intelligence. So where do we go down that line, I think is important besides just saying, um, we can do this to save lives. And always behind this saving lives, we have to be very cognizant of the financial factor, because always it's about making money. And so with sickle cell disease, they invested money, the companies that do this, and they're not going to give it away. And so this is part of capitalism, and capitalism meets science. People do this to make money and, of course, to improve lives. But the financial stakes are always underneath. And we have to be really, I think, cognizant of that and say, do we just go willy-nilly and do things to animals because we can improve people's lives? And then we say, oh, we're going to improve people's lives. And it's like, who's going to get access to this? Who's getting access to sickle cell treatment? Who's going to get access to beta thalassemia treatment? There was a big piece in the New York Times maybe about a year ago about this baby who had what we call an inborn error of metabolism, and it was one letter. And they worked with Doudna's lab, and they said it was free except for the cost of the materials. And they CRISPR'd the kid, and the kid was suffering, and the kid was going to have a very bad life. And they used CRISPR, and the kid is, as far as I know, still okay, which is phenomenal. But, you know, that's also a PR for doing this. And I want kids to be cured. I'm a pediatrician, but I also want it to be available for families. And I haven't been convinced because we're in a mode in medicine of profit. It's a medical industrial complex in the US. And so this is why there's such terror and turmoil at my institution, for instance, at Harvard, because $2 billion of research money, it wasn't for the English department at Harvard. It was the medical school and School of Public Health. And so that has enormous repercussions. Um, and, I think we have to be really much clearer about transformational research, that research is done, but not all of it is going to like make a cure. And people want, things to be cured. Of course they do, because when they have a family member who suffers from something, they want a cure. And I think one of the things I've learned about after COVID is that people want definitive answers. They want to know, like, if I get the vaccination and I still get COVID, well, I have long COVID. And we don't still know enough about COVID because it's what we called a novel virus. It was new. And so with measles, there's more definitive means you know everything. So even with measles, in the past year, there was incredible research done that showed, because some kids were dying again who hadn't been vaccinated, why do some kids die? And we started to understand how measles affects antibodies. And we didn't really have a clear sense of that until recently. The research showed us that. And so that's why some kids have less protection because the measles has also affected their resistance to pneumonia and things like that. And
Mhm.
so research is ongoing, and there is no definitive answer. So when RFK is saying, Tylenol causes autism, that's definitive. That's of course ridiculous because there's no one thing that causes autism. We know that from many, many studies. It's probably a combination of many genes, maybe parents' age, and environmental factors. And autism isn't one thing. It's been, changed in the DSM. So that's why the numbers have gone up because it's a more expansive definition and it includes more people on the spectrum instead of just severe autism. And so autism isn't just one thing or one gene. It's a multifactorial um,
Sure.
syndrome. And so I think it's really incumbent on the public, and as scientists and physicians, we have to tell our stories better that medicine isn't definitive. There's always side effects. That's why, if you watch a commercial and they talk really fast at the end and it's like, and it
Yeah.
can cause death and cancer and, whatever, it's because we're all human beings, but we have different genomes. And that's why I remember thinking in medical school when they told us that people with schizophrenia, one third responded really well to psychotropic drugs, one third kind of, and one third not. And I kept thinking, like, what does that mean? Like, why? And the answer is because we have different receptors. And some
Mhm.
people have receptors for certain medications that will help them, and some people may not. And so that's why we all don't look the same. And so we have so many different combinations of genes. And so this personalized medicine looks at that fact and starts to look at how do we give you a medication that's dedicated to you. And we're doing that work, of course, mentioned CAR T cells, where we're giving people their own cells, in a sense, to fight cancers. We're doing personalized medicine. And so we're doing amazing things to alleviate suffering, but we're also jumping forward for financial reasons and profit. And I think we have to really address those topics. And I think it's incumbent on scientists to be the ones to start really telling their stories, not saying, well, I'm a researcher, let the public, somebody else should tell this story.
Mm-hmm. Mm-hmm. It's interesting, because we've talked about human health, and we've dabbled a little bit in agriculture and animals. I'm very interested. You mentioned earlier, right on, that these genes, many of them, right? They don't fall out of the sky. They're quite ancient, and especially when we look at the microbes and other single cell organisms on this planet. And there's been this trend in these geoengineering concepts because, hey, there's microbes that are pretty good at eating oil and dissolving plastic and maybe soaking up this radiation and this stuff over here. I'd love to get your perspective. I know you're a clinician, and but nonetheless, I know you've talked to everybody out there about these topics. Whether it's cleaning up the ocean or getting rid of these mosquitoes over here. Again, it comes back to this off-target thing. Yes, we may be very good at doing it, and it might make a better world, but we got to keep our eye on what else.
Right.
When we start CRISPRing the world, let's say, what
Well,
we're
we can't
doing.
predict, we're not very good at predicting the future.
No.
So during the Industrial Revolution, that changed everything, but also, you know, forced us to use fossil fuels, which we know have a deleterious effect on the environment.
Yeah.
So there was a cost benefit. Same with plastics. Plastics, changed people's lives. But plastics now, we don't really still know enough about, microplastics and how that affects health
Yeah.
and how that affects the environment. And so I think nuclear energy. I mean, we can like kind of list these things. So CRISPR falls under that category that we don't know sort of what the future will be, because that's the nature of doing science. You accrue knowledge and you build it. And so, but we have to like, I think, really kind of try to imagine that what we're doing now could have just unbelievable repercussions in the future. And so that's hard to do, and that's why we need scientists because they can tell their stories, and it's not just about I want to do my research, let me alone. I don't want to have oversight. I mean, I've talked to many scientists who say we can monitor our own, and I said, well, and I use the example, have you ever seen someone jaywalk? Have you ever met someone who had a little bit too much to drink and went driving? I said,
Mm.
well, and they say yes. And then I say, well, we have laws that don't permit people to do that, and they still do it. So I don't trust scientists to oversee their own. And so I think we need to have some regulations that are more specific about controlling access to certain DNA pieces and things like that so that people don't build crazy bacteria or viruses and things like that, rogue scientists. So we have to think about these repercussions down the road, and that's really hard to do because, wow, we can cure diseases. Let's go forward and we'll make money like oil companies did and plastic companies did and nuclear energy did. And now this. And it's like, whoa, okay, have we learned any lessons?
Mm.
So I want to talk about that. I'm not saying we shouldn't do CRISPR for sickle cell disease, but it raises a lot of issues about how it's going to be used in other ways that we
Yeah.
need to talk about.
Yeah. And one of the, and this might be an interesting topic for a show or a movie or something you do in the future. But a couple last year, I hosted Ian Watson, who is the Deputy Assistant Secretary of Defense for Chemical and Biological Warfare at Defense at the Pentagon. And he was on this thing called the Planetary Protection Committee at OSTP. And when we were talking about planetary protection, I always thought it was sort of Andromeda strain stuff, like, oh, if something weird comes down and how we deal with it. But they were actually looking in the opposite direction. It's like if we send microbes out into space, And we, as an experiment, we put them on Mars or somewhere else. We can contaminate that world before we even get there and cause all sorts of problems out there. But at the same time, we can create microbes that are pretty good at surviving in space, and make little space travelers and to do interesting build stuff for us or whatever the case may be. I think it's the kind of futuristic thing, but nonetheless, something else. I mean, we talked to everything about this little planet, but we're getting off this planet lately. We're shooting a lot of stuff up into space, and I was just interested in whether in a lot of these thought leaders that you talk to, if anyone has sort of broached the topic with you about beyond Earth and applications of CRISPR.
No, but who knows? I mean, because we haven't really found organisms yet. There's the possibility that life can exist
Mm-hmm.
in places, but who knows, you know?
Yeah.
I mean, that's again, I can't predict the future. I couldn't predict what, we've known a long time what burning fossil fuels does. We didn't
Yeah.
just learn that in the last 10 years.
Right.
Exxon did it 50 years ago. But that's a warning
Right.
that there is a price and we have to be very careful. And when we're starting to play with human evolution or animal evolution, then we have to think even harder about where we're going.
Mm-hmm.
Um, you know, and there's George Church from Harvard is making taking woolly mammoth DNA and putting it into elephants, and who knows what that's going to do. We just don't know enough about the genome
Right.
to know, what we're doing when it's had billions of years to evolve.
Yeah.
And we've had, I don't know, 10 years of CRISPR really. And it's like, be careful.
Yeah. Yeah. What's coming up next for you? I mean, the book is out there. Obviously you're still lecturing on global health and social medicine at Harvard. What else is going on in your neck of the woods? Anything that you want to mention while we have you
Sure.
today that I did not touch on, but
Well,
please.
I have my master's degree program at Harvard, so we're just started our fourth year with incredible students. It's a program in a Master of Science in Media, Medicine, and Health. So our students design a project drawing on the arts, humanities, or media to promote a health issue, like improving vaccination rates and Pap smears amongst women who are at risk for cervical cancer, which is completely preventable with the Gardasil vaccine and doing Pap smears. And yet, over 4,000 women in the US die every year and over 350,000 around the world. 37% of women in Uganda who die from cancer die from cervical cancer, completely
Mm,
preventable. So I have students working on those kinds of problems, drawing on the arts, broadly defined poetry, dance, documentaries to promote health and inform and the public and help the public take action. And then I do that online globally for mostly healthcare providers who are interested in it's like a boot camp. So it's online. If you just like Google Neal Baer Medicine Harvard, you'll see the programs. And then I still do TV.
mm-hmm.
So I consult on shows uh, and give them notes or assessments of their scripts. I still develop shows and I work as an executive producer. So they're on documentaries. So there's a documentary coming out called I Was Born This Way that was just at the Tribeca Film Festival. So that's coming out soon. And keep my hands in developing TV series as well and continue to write about these topics.
Awesome. Well, it's a very strange time we're in, and we clearly need a lot of it.
Yes,
What you're doing, so I applaud you, and I look forward to continue to follow your work. Again, for everybody out there that's going to be listening to this episode across the various podcast networks, or who will be watching on the YouTube channel. Again, you've been spending time with Dr. Neal Baer. Pick up a copy of The Promise and Peril of CRISPR at all major booksellers. We also put the link to the media, medicine, and health program at the Harvard Medical School that Neal is the co-director of. But Neal, again, I want to thank you for taking time out of your schedule to come talk to us for a little while today. Thank you for everything you've been up to at this important intersection of media and public health. And as we like to say on our show, thanks for helping to create a better tomorrow through the way you educate, the way you entertain, and get the message out there. A really, really great story.
Thanks for having me. It was really fun to chat with
It
you.
was, it was a great discussion.